Hello everyone, welcome to our 91st AeHIN Hour. If you need assistance, please feel free to send us a message through the chat window. And if you're having difficulties in configuring your connection, please log out from the session and rejoin again. You may also use your smartphones or tablets to join by using the webinar ID 946-748-147. Please be reminded that all microphones are muted throughout the meeting, and for comments, please use the chat box, and for questions, please use the questions box. Tonight's speaker is Dr. James Kariuki, who is one of the ADX profile co-authors, which is developed under Integrating the Healthcare Enterprise Quality Research and Public Health domain. We will now call on our speaker, Dr. James.
Thank you. Thank you, Cha. I hope you can see the presentation.
Yes, but I'm presenter slides now. Dr. James, could you try switching the display?
Okay. Okay, can you see it now?
Yes, thank you.
Thank you, Cha. I'll begin by reading the disclaimer message. This presentation does not in any way represent the views of CDC, so just to note that. And thank you everyone for attending this webinar and the opportunity to present to all of you. I'll begin by going through a brief outline of what I'll be presenting during this webinar. So for the outline, I'll go through a brief overview of background, where I'll look at where did ADX really begin, and why do we need it? And then I'll talk a little bit at length about the ADX profile, and then just touch a little bit on the impact of ADX. I'll try to go through the presentation as fast as I can, and just to create a time for conversation at the end of the presentation. So on the background, as you can see on this slide, increasingly we've had a number of electronic information systems emerging and being implemented, and they're currently in use in many countries, many facilities, for different purposes, from patient-level information systems to human resource information system to national HMIS, and even dashboards that enable countries, province, subnational levels to see or monitor the progress of the interventions they put in place. And on this next slide, one of the things I'm highlighting is what is this HIS interoperability challenge. This is a scenario that is a case in most countries, where we have at health facility level EMRs implemented, and from the EMR, they either generate a monthly report and send it to the district or subnational level for data entry into the national system. Or if the facility have access to the national aggregate system, they are able to key that data in. So one of the biggest challenges is the fact that we enter patient data manually in most cases, either as a point of care or retrospectively, and at subnational level or getting those reports into the national system, we are also re-entering that manually. So this is causing a challenge in the sense that it creates an opportunity for transcription error during that entry. And the other challenge is the fact that as the need to enter this data manually increases the burden to the human resources at the facility, and depending on the workload also, if you think about the timeliness of getting these reports into the national system, it takes time for it to be entered at the subnational level into the national level. So in this case, we're having delayed reports. We're having increased burden to the human resources who enter this information into the national system, as well as the delay in getting the accuracy of the reports be available for use at the national level. And this is wasn't at in resource limited environment where we have, for example, a nurse taking time off to see patients to enter this information into the national system. And just to revisit this, the impact of data quality and availability. In some cases, you find that the timeliness in accessing accurate information is key to putting in place interventions to control or even slow down the spread of a disease or epidemic. But with this all, we have an opportunity through interoperability to both improve availability and quality of data that we use, especially given the resources that we have available in different settings. So this where we kind of begin exploring the automation or electronic reporting of reports. And the first thing we did was to come up with an objective. In this case, this was our first objective. And the question we had is it feasible to automate PEPFAR HIV care and treatment indicator data from an EMR to a national system? And in our case, we used DHIS2 and OpenMRS. So with this, we began by exploring options that are available to exchange information. Some of you may be familiar with SDMX HD, so we explored that. And then we finally got in touch with Bob Jolliffe and some of his colleagues who had worked on a similar project in India. So they had developed a DHIS2 reporting module for indicator exchange, and that's where we began collaborating, working on this project. So we took the module and tested it in our lab environment here at CDC, and with this we were able to come up with a number of things that indicated or kind of gave direction on how we can proceed with this process. So what we did within our lab environment was to deploy the two applications, and then we reviewed the indicators that we needed to exchange between the system, and we went through the process of configuring DHIS2 to receive the indicator data by adding the HIV care and treatment indicator data elements in it. And then within OpenMRS, we configured it and added dummy data that's available from OpenMRS website. And then what we did was to configure OpenMRS to generate the indicators using SQL statements. That's where the module was at that time, but there are some changes that have happened since then. And then through the module, we were able to link the two systems, and we generated the indicator data from OpenMRS and submitted that to DHIS2. So one of the things we were keen on was on the last step, which is step 9, to document this process step by step, with the intention of sharing it with colleagues, with partners on this process, so that we can share that information and learn more about how they can address the issues they are facing. So in a lab environment, we were able to achieve electronic data exchange between OpenMRS and to DHIS2, and all this was based on the DXF format that is supported by DHIS2. However, that was not the end of exploring this the fact that we are able to get data from OpenMRS, generate the indicators we need, and send those to DHIS2, we're like, how does this look in an actual environment? And this is where we moved on to our second objective. And the question that we wanted to answer is, does this automation process, are we able to scale up without increasing burden to the human resources, as well as ensuring that we have quality data and it is available. So with this, what we did was to set up a field test in Kenya. And one of the reasons we picked Kenya is because they had DHIS2 as the national system, and they've several facilities are using OpenMRS within the country. And around that time, the country was in the process of scaling up to an additional 600 facilities, EMRs to an additional 600 facilities. So we thought at least learning how that works will help us kind of provide additional information on how to integrate this as part of the core process of reporting. So we selected one facility, which was a district hospital, and the reason for district hospital is because it had a relatively large population of HIV patients. We also selected one that is supported by, that's under the Ministry of Health directly, as well as it was running a Kenya EMR, which is a customized version of OpenMRS, and had been used for a period of time to enable us test that process. So in terms of evaluating in the field test, what we did was to compare the existing reporting process and the process that we had put, we were planning to test, which is automation of indicator reporting. So some of the things that we were looking at or collecting were the number of staff required for reporting, data quality, and that was looking at the accuracy of the data being the accuracy of the data within the facility and the data that had been sent to the national system. And also the other one was, how fast do we get a report from the facility to the national system? Within this short study, we had a number of limitations in terms of what we were able to do and what we couldn't do. One of the things we couldn't work on at that time was to look at the quality of patient level data. What we were focusing on was what's the accuracy of the numbers being represented at the facility compared to what had been submitted to the national system, both manually and through the automated process. So in the next few slides, I'll share the results, and you can access this through a paper that has been published, and it has more details. But one of the things was, as you go to facilities, there are several things that you come across. What we really expected was to evaluate the expected reporting process, where our assumption was that the facility generate the reports from the EMR and manually enter into DHIS2. But going through the workflow, we realized that not all reports are available from the EMR. So the process they use is tallying the numbers from the registers and combining with some data from the EMR and then reporting that. So this one thing that we didn't anticipate, but we found at the site. And overall, what we realized, we noted from that is for the current reporting process, which is the fast swim lane, each activity needed at least one person. And for that process, there are 5 different activities that the facility needed to do: collect the registers from different departments, tally the data, and then compile the indicator report, review it, and then enter it into DHIS2. So compared with what we expected, where we have one person to generate and print the report, another one to review, and another person to enter that data. So we see as we move from an entirely manual process to a semi-automated and automated process, we kind of reduce the number of people you need for the tasks. And generally, what seems to happen is reducing the number of steps you need to get a report being generated and sent to the national level. So in terms of data quality, what we compared was the data that we looked at the reports that were at the facility, and we pulled similar reports from the national HMIS, and we looked at the number of data elements that had accurate value, meaning they were identical both at the national system and at the report at the facility, which is represented by the blue bar for these months that are shown here from July 2013 to January 2014. And as you can see, the number of accurate data values are kind of fluctuated month to month. And we also looked at the number of missing data values, which you can see in green. In some months we had more values missing, in some they were pretty close. And then the other one is where they had values in the report and the national system, but the values didn't match. So we looked at we looked at that and kind of compared that. And if you look at the graph below where we automated that process and compared the values, you realize that all the values that were generated from the system and electronically sent all of them were accurate. It is expected, but one of the things we wanted to do is to show that difference and what this could mean when we increasingly move from manual reporting process to automated process. The last one was the amount of time we need in reporting. And one caveat for this is for the current reporting process, we were only able to observe this for 1 month, which was in October 2013, and measure how long it took to go through the manual reporting process. And as you can see, that whole process from collecting the registers, which had some estimation, to tallying and compiling the report and entering this into DHS2 took about 375 minutes, which is about half a day work for one person. Comparing this to the expected process where they generate the report from the EMR and then manually entering that, it drastically reduced the amount of time. And when you look at this too, a lot of time is actually spent preparing the report compared to how much time you enter the report. So in this case, entering this data into the EMR took about 30 minutes. So generating the report was pretty fast. And for the last process where we automated this was almost instantaneous. So there was a drastic reduction in the amount of time it took to actually generate and post the report into DHIS2. So overall, this is our conclusion on this. As we move from transition from the manual reporting process to a more automated reporting process, we are able to improve completeness and accuracy of data, and also reduce the number of staff required for reporting. Meaning, if a facility doesn't have dedicated data people, at least can still achieve reporting by reducing the amount of time needed to exchange to meet the reporting requirement to the national level. So overall, this was one of the activities that kind of informed what it means to electronically exchange data between systems. And with the collaboration and with Bob Jolliffe from University of Oslo and others, we started exploring and asking ourselves, how can we move this to the next step? And one of the major questions was, if we go to a setting where we don't have DHIS2, how can we leverage on the existing format that we used for example, in this automation process to still exchange data between systems? So this was the beginning of our conversation for to develop at least a standard that will enable us to move that data without being attached to a given system. So and with these, we ended up working with integrating healthcare enterprises, and we developed a ADX profile, which is aggregate data exchange profile, and one of the things we focused on was to look at how can we still enable data exchange with a simple exchange format that will enable moving data from one system to another. So we based this profile on SDMX version 2.1 data structure definition, and this one of the requirement by integrating healthcare enterprises. So they don't focus on developing new standards, but it's leveraging existing standards and creating a profile that enables us to leverage the pieces of existing standards to ensure interoperability between systems. And as I go through this process, this presentation, you'll see how this process come together. So and in this profile, what we do is describe ADX specification, especially on how an SDMX DSD is employed to develop an ADX conformant message schema that enables us to generate ADX message that is conformant to the specification. And all this work we've done under the Quality Research and Public Health Technical Committee, and this has been published as a supplement. And I have the link is down there. You can go and look at the current version of ADX profile. So to dive a little bit into the profile itself, so with this profile, we define one of the things we did was to identify the use cases that this profile is going to address, and these are some of the use cases we have out there. One is community health workers filling in routine reports and submitting those to national system or community health system. The other one is reporting healthcare worker data from a human resource information system into a national HMIS, for example. The other use case is reporting routine reporting from electronic medical record systems or patient level system. A lot of that reporting is done from individual level system. The other kind of reporting is where we have data being reported from one HMIS to another, or one aggregate system to another. So these are another use case that ADX describes or fulfill. I have the last one, reporting of supply and logistics data. These are use cases that can also be included into this use case, because the key thing with ADX is being able to generate aggregate data and format it in a way that the receiving system can consume that and process it. So just to talk a little bit about two use cases which are common, and these are two use cases where we've done quite some work so far. And as you can see on this image, we have routine reporting of indicator data from electronic record system. So at the end of the reporting period, a report is generated from the facility EMR, and this data is sent into a national HMIS. So this is something that there's a process that routinely happen at facilities at the end of each month. But beyond that, you find that each country need to report also national indicators from their national system to a global data repository, for example, WHO. So that's this is the use case where you go, a country will go into their national HMIS, generate the required indicators, and push those to a global system. And another example is PEFA support. We see a lot of reporting from countries that are supported by PEFA. So that that's another example of where this use case has been applied. And as you can see, like the increasing need for data or the demand for data to accurately report or monitor diseases is increasing. So we need to get more information accurately from countries to the national level. So diving deeper into the ADX profile. So within the profile, we have several actors that have been defined, and as you can see on this slide, we have a content data structure creator, we have a content creator, and a content consumer. There's also a content data structure consumer, which has not been shown in this diagram, but I'll explain a little bit more about that. So mainly the work of the let me move to the next slide on the technical solution. So this is the same image but represented a little bit different, which shows how the different pieces of ADX come together. So as you can see on your extreme left, there are different jurisdiction, which could be a country or a program or an initiative. So within ADX profile, these are what we call jurisdiction. And then up here we have the SDMX, statistical data and metadata exchange, DSD specs, which are combined together. And the work of the jurisdiction is to define the different code lists that will be exchanged between the content creator and the content consumer. So some of the things they define is what are the data elements we need, or what's the reporting period. They have a list of the facilities that need to report. So that's the information that's taken by the content data structure created together with the DSD SDMX DSD spec, and with that we're able to create an ADX specific DSD, and from that ADX DSD the specification describes how you can create an ADX conformant schema, and these schemas have several purposes. One of them is to kind of show which data elements need to be generated by the content creator, and the other purpose is to actually to validate the ADX conformant messages that have been generated, and I'll talk a little bit about this in the next slides. But one of the revisions that we recently did was to improve on how the validation is being done by being able to validate both the structure and the content of an ADX message. So through that process, at this point, we have a data structure content consumer, which could be our content creator. So basically what a content data structure consumer does is to take the metadata that's provided and define what need to be reported. So right now, the use cases we've seen, most content creators also act as the content data structure creator, and in other cases, actually, and in other cases, actually, the content consumer is the one that acts as a content data structure creator. In this case, if you're familiar with DHIS2, the first thing you did, and as you saw in the process that we went through, was to define the data elements that you need to report about. So basically, at that point, your DHIS2 is acting as our content data structure creator to define what elements need to be reported, the period for reporting, and that's provided to the content creator to be able to generate the message in that format. So the next thing is transport specification. This is one of the recent addition to the profile. So with this, what we did was to add a transport specification, which leveraged on our experiences implementing ADX in several EMRs, and this has been defined as a ADX post content, which is based on a HTTP request. And this can be implemented in two ways. One is when asynchronous is false. So in this, what this means is during the reporting period, and I'm talking about the image on your left, the content creator generate ADX message, and using ADX post content, it sends this message to the content consumer. So when asynchronous is false, the content consumer takes the message and processes it and sends back ADX post result to the content creator about the status of the processing. So when asynchronous is false, this happens immediately. On the image on the right, this is where asynchronous is true. And how this happens is the content creator sends a ADX message to the content consumer, and this message is queued for processing later. And once the content consumer processes the message, it sends an ADX post result later. But within posting the message and getting the result, there are several things that happen in between, and one of them is to check the status of the processing of that message. So on this next slide is to highlight the versions of ADX that we've had. On the right, we have the first version, which was released in August 2017. This version have gone through one connectathon test. And on the right, we have the revision 2.1, which was released last week for trial implementation. So this is the profile that we are looking forward to begin testing during the AeHIN Connectathon in January here in US or around April next year in Europe. So these are the two versions. So the only difference between these two revisions is that with revision 2.1, we've added additional information on validation of ADX messages. So there's an additional validation schema, which is a W3C XML schema definition, and also an ISO schematron, which checks both the content and the structure of the message. In addition to this, there were improvements on how ADX handles data element disaggregations. So that was one of the goals with this revision. And the other revision was addition of transport specification, which I just talked about on the previous slide. So a little bit about the value proposition. ADX can meet reporting requirements in resource and technologically diverse settings. So we can potentially use it in low, medium, and high resource settings. The other one is that this ADX is actually a significant step towards providing a standard-based profile for aggregate health information exchange. And this can facilitate development and implementation of tools to support information workflow at the local, national, and global level, as you saw on the use cases that we are addressing. The third one is to support electronic reporting of aggregate data. And the main goal of this is to improve on the slow, labor-intensive, and error-prone manual reporting process. So these are really key in terms of how ADX is going to move forward and shape what we do moving forward. So on the next few slides, I'll just highlight about the AeHIN Connectathon that ADX profile underwent back in early 2016. So a little bit about AeHIN Connectathon. This is a forum or an event where system exchange information and you get systems from different vendors, and each system perform transactions required by their role, either as a content creator or a content consumer. And in the case of ADX, as we continue getting content data structure creator and consumer, all those can be tested based on the profile published. And this provides a detailed validation for the participants on how the system complies with the AeHIN profile. In this case, it will be ADX. So a little bit more about the 2016 AeHIN Connectathon. There were 3 systems represented for ADX test. We had, and these were submitted through OpenHI and also Promise system that was submitted through Northrop Grumman. So for OpenHI, we tested OpenMRS, DHIS2, and the Promise system, and we used 8 HIV excuse me, data elements that I've outlined here. So in terms of the test, the content data structure creator, which in this case was DHIS2, had all the data elements, the 8 data elements defined within it. And then in terms of content creator, we had OpenMRS, Promise, and DHIS2. And in terms of data, content consumer, we had DHIS2. I know one question that you'll probably have is why did you have DHIS2 as a content creator and a content consumer? A good example will be in countries where they have DHIS2 running as a national system, and the PEFA system data, which is based on DHIS2. So both are based on the same platform. But they need to exchange data depending on how they are organized. So we needed to test DHIS2 both as a content creator and a content consumer of ADX messages. And so far from version 2.20, the capability to both create and exchange ADX message exists. So this slide is a highlight of the test results, and most of these are tests for data structure content creator, which is at the bottom, and then both DHIS2 as a content creator and a content consumer, and OpenMRS as a content creator. So these are the test results, and based on the test we conducted, those are they were able to verify that the exchange works. This was a good learning experience for all of us, and we were able to come out with some things that we needed to work on, especially some of the changes that we've added to the revision 2.1. These are the results for Promise as a content creator. We were not able to test Promise as a content consumer, so that's something that was pending at the end of the Connectathon. So here are some of the efforts that are currently going on towards ADX adoption. So as I mentioned, DHIS2 has incorporated ADX support or capability from version 2.20 and above. And then another initiative is DATAM, which they've been working on support using ADX for data reporting workflow. So there are several initiatives that have been going on to test exchange of data using data. In terms of EMRs, several EMRs have been enhanced. There's work going on OpenMRS to support exchange of to support reporting using ADX, and there are quite a number of improvements, especially on how the report is generated and integrating the modules within OpenMRS to better support ADX. Also, there's IQ Care and IQ Tools that we have tested for automated indicator reporting, and we've been testing on how that can support ADX, and work has gone into that, and it is ready actually to begin exchanging data using ADX. So I'll move on to the last section of my presentation, which is going to be a little bit short, but it's kind of coming back and thinking about what is the potential impact of ADX on automated indicator reporting, which is the key thing that we need to look at when we are facilitating or developing data exchange between systems. The first thing is this is a huge step toward a standard-based automated indicator reporting, and with a few projects or activities that have been done recently. One of them is PEFA and host country governments being able to exchange HIV indicator data, the support of other routine reported health data from the facility, the potential to use this for example, reporting numbers on malaria and Zika, for example, and other diseases that are reported from the facility, and also other aggregate reports, being able to get aggregate numbers of, for example, the number of lab tests conducted, also logistics, pharmaceutical supplies and such. So this is really key in terms of coming to a point where we are able to use a standard-based process in reporting. The other impact is improving the accuracy, completeness, timeliness, and availability of indicator data. So this is one of the things that I know most of us have been working on. How can we improve data quality of the data that we are using for decision making? How can we improve it to enable us monitor program and progress of results better? How can we use high quality data to support implementation of health services across the countries? So this is really going to be key, especially when we are able to increasingly show that automation and interoperability is able to support that. And then another impact is there's a step toward harmonization of health indicators, both locally and globally. As we continue to adopt and use ADX, one of the things we've been discussing and exploring is how can we begin sharing this the data structure definition within a local setting, across countries, across provinces, and even globally, because this will enable us to increasingly define our indicators better and also have definitions that are harmonized. And in that case, we can easily compare the data that was reported, for example, by Thailand to the reports that were submitted by Swaziland. So it will get us to a point where we can actually compare the achievement or the progress made by different countries. So with that, thank you very much, and thank you for listening to me. And I'll hand it over back to Cham.
Thank you, Dr. James. We're now open for questions. If you have questions, please type your questions in the questions box. If you cannot find it, you can just type your questions in the chat box. We'll be waiting for your questions. Thank you. Hello, Dr. James. We have our first question here. It's from Dr. Elaine Baker. It reads, can this standard apply to complex structured data such as cohort reports, where an indicator is attached to 2 periods instead of 1? For example, the number of people who started art in January who are still on art in June?
Thank you for the question. Thank you, Elaine, for asking this question. I may need a little more clarification, but just from looking at the question, depending on how you define the period for reporting your indicator, which in most cases is actually defined within the indicator guideline, you can actually you can create different ways to use ADX to report this. So if you look at ADX profile, it has different it has different time periods that you can report on. Let me share a page on the ADX profile that shows some of the of those periods. Can you see my slide?
Yes, we can see your screen. Thank you.
Sorry?
Yes, we can see your screen now, Dr. James.
Okay. So if you can look at the screen, so there are times and time intervals for ADX. So this define different periods that you can use for indicator reporting, which could be years, months, days, even time. So there's a way you define you define this. So one of the key things with your question, Elaine, is it depends on how on the period that is defined for this cohort, the number of so if you're able to create a data element within your receiving system of the number of people who started ART in January and are still on ART in June, in that case you create your query. If I use OpenMRS example, if you can aggregate the number of people who started in January and are still in June as a number, you can report on that. The key thing is defining what period will you be reporting that for.
All right, thank you, Dr. James. We have another question. This one is from Miss Aliyah. It reads, how is the HIS2 different from what ADX is proposing, or are they complementary?
Sorry, can you repeat the question again?
Yes, Dr. James. It reads, how is the HIS2 different from what ADX is proposing, or are they complementary?
HIS?
Okay. The HIS2.
Oh, okay. So I'll use an example of a different standard to kind of explain this. So for example, HL7 message, which HL7, which most people are familiar with, that's a standard that's used to exchange patient level data, for example, from a lab system to an EMR. So in this case, DHIS2 is different from ADX in the sense that ADX is used to exchange data from one system to DHIS2 or from DHIS2 to another system. So it's so they are complementary in the sense that DHIS2 leverages ADX to exchange data between systems. Or maybe to expand on that further, as HL7 as HL7 is to an EMR, ADX is to DHIS2, but I'm using a simplified example there.
Thank you, Dr. James. We have another question. This is from the Engineer Derek Ritz. Engineer Derek, would you like to speak on your microphone to ask this question? Do you have a microphone now?
Sure. Thank you, Cha. James, firstly, a compliment. What an excellent presentation. And this is 2 days in a row for you because you did a wonderful one yesterday as well for the IHE webinar. Just a clarification regarding how asynchronous data is exchanged. If you're in asynchronous mode, does the content consumer, the target system that the data has been submitted to, does it actually send a message to the content creator, or does the content creator have to poll for the status of the submitted message if it's been sent asynchronously? I think it's the latter, but please clarify for me.
Thanks. So the message that is sent by the content consumer is a status message saying that the ADX message has been received and queued for processing, and from that point, what happens is the content consumer will send get messages to the content consumer to check the status of the processing, to the point where after a content consumer process the message, it will send another status message saying the ADX message has been processed. And depending on how that has been implemented, either it can send a message saying this is the status, or you can get the status of your process here. So the message that's sent immediately is just an acknowledgement saying we have received your message and we have queued it for processing.
But it's always the response. It's always the HTTP response to a request from the sending party, yeah?
Yes.
Okay, so it doesn't actually initiate a broadcast. It is always the response when you poll.
Yes, it is a response when you poll, yes.
Okay, excellent, and thank you. Chuck, can I ask a second one?
Yes, please go ahead, Engineer Derek.
James, you and Bob Jolliffe were both advisors on a project where I am doing some work to gather information regarding PEPFAR expenditures, and your advisory help to our project was very beneficial, and thank you for that. We were developing a content specification described as an ADX schema to collect expenditure information. Could a similar pattern be used to collect defined aggregate message types for other use cases? And I'm thinking specifically about the PEPFAR program again. Could a content specification be developed using ADX for HIV content, for example? I think that was what your use case was gathering, was it not?
Yes, Bob, and I think part of it is preempting the next project around or the next activity around ADX, and what Bob and I and a lot of people who've been working with us have been looking at a way to get more information on how to implement ADX. And one of our next steps is to define the core HIV care and treatment indicators in a way that that can be shared as a DSD that system developers, vendors can take that up and use it within their system. And we are looking at defining that in a way that it can be used across countries and across programs, especially focusing on how WHO defines those indicators. One of the things that we are looking at being maybe not different, being complementary with what ADX is doing, is kind of taking one use case that we are familiar with and developing a content profile that is specific to a given disease, for example. So we are planning to do that and share with that widely, and also in the process create tutorials to help users report on those indicators easily. So that's one of the plans, so that when you look at ADX, that will be the platform to report different diseases using different content specifications.
I know that AeHIN is a key player in the Health Data Collaborative, and I would hope that something like this could be aligned with that work. That sounds really promising. I'm very happy to hear it.
Thank you, Derek.
Seeing that there are no more questions, I think we can wrap up this session. We would like to thank Dr. James and all our participants who actively joined this webinar. For those who came in late, we'll be posting the webinar materials at ahin.org. Thank you.
Thank you.